So 1 minute, sir. And today's plan for talk will be, I'll be starting with the introduction and discussing about the indications of ventilation, and will be explaining certain terminologies and concepts. And I'll be discussing about the oxygen therapy, the indications for initiation and weaning of the mechanical ventilation. What is ventilation and what is respiration? Ventilation is defined as the movement of, hello, hello, sir, am I audible, sir?
You are audible. Request all of you, please mute. Go on, Dr. Vanitha. Carry
Yes, yes. Ventilation is defined as the movement of an amount of gases in and out of the lungs, whereas respiration is defined as the exchange of gases, that is oxygen and carbon dioxide, across a membrane at the alveolar level as well as at the cellular level. What is the difference between the physiological and mechanical ventilation? As we all know that physiological ventilation or respiration is consist of two phases, that is inspiration and expiration. Inspiration is an active process which is associated with the contraction of the respiratory muscles like diaphragm and external intercostal muscles, thereby increasing the capacity of the thorax, creating a negative pressure inside the thorax, which leads to the air entry into the thoracic cavity. Whereas exhalation is a passive process, which is because of elastic recoil of the lungs and the thoracic cage. Whereas in mechanical ventilation, we do deliver a certain amount of gases through a machine, which is a kind of artificial respiration, which is of two types, can be negative pressure ventilation or a positive pressure ventilation. In negative pressure ventilation, a negative pressure like subatmospheric pressure is created around the patient's thorax surface, which leads to the expansion of the thorax, thereby pulling air into the thorax. And the development of respiratory care is dated back to the Galen's observations, who is a Roman physician, with his observations on respiratory anatomy and physiology of respiratory systems. And he is the first person to introduce the concept of mechanical breathing by blowing air into the larynx of a dead animal through a reed. Mr. Philip Drinker is a pediatrician who invented the tank type negative pressure ventilator, which he used in treating polio affected children in 1928. And the commercial version of the negative pressure ventilation is discovered by John Emerson, and it is called as iron lung. Iron lung is nothing but a metallic box that engulfs the patient up to patient's neck. And the first picture shows the iron lung, and the second picture shows the use of iron lung during the polio epidemic. And as I told before, mechanical ventilation can be a negative pressure ventilation or a positive pressure ventilation. And the development of positive pressure ventilation was also along the same around the same timeline, and it has become the predominant form of ventilation used nowadays. And the in positive pressure ventilation, we do deliver a certain amount of gas to the patient's lungs with a positive pressure gradient maintained between the airway and the alveoli. So as we all know that the air moves from high pressure area to the low pressure area. As the airway pressure is more than the alveoli pressure, air will be entering into the alveoli from the airway. And the initial positive pressure ventilators were called as bird ventilators, which were patient triggered and pressure cycled ventilators. And the positive pressure ventilators can be of two types, which is volume cycled ventilators or pressure cycled ventilators. Initial ventilators were pressure cycled ventilators, and the second type of ventilator were Bennett valve ventilators, which came with a flow sensitive valves. And later came the volume ventilators, where a preset tidal volume is delivered to the patient's lungs, whereas the pressure is variable. And the first picture shows the bird ventilator, second picture shows the Bennett's valve ventilators, and the third shows the initial volume ventilators. As we all know that the primary indication for mechanical ventilation is acute respiratory failure. Acute respiratory failure can be of two types. Type 1 respiratory failure is called as hypoxic respiratory failure, where a pathology is seen in gaseous exchange, that is, pathology lies in and around the alveoli. So, examples for type 1 respiratory failure is seen in lung related issues like pneumonia um, and pulmonary edema, etc. And the three main pathophysiological mechanisms seen in type 1 respiratory failure is ventilation perfusion mismatch. As I have told earlier, here there will be deficiency in gaseous exchange. That is, ventilation will be decreased, whereas the perfusion is maintained. So because of this, increased blood flow will be there, but there will be decreased gaseous exchange, resulting in increased venous blood shunting across the ventilator alveoli, which is called as intrapulmonary shunting. And type 1 respiratory failure is also associated with decreased functional residual capacity. Functional residual capacity is nothing but the amount of air that will be present after passive normal inhalation. And the type 2 respiratory failure is called as hypercapnic respiratory failure, where there will be ventilatory pump failure is seen. The causes being decreased respiratory drive, which is seen in conditions where the respiratory impulses from the respiratory center to control the respiratory muscles will be inadequate. This is seen in patients post anesthesia or in patients with drug overdose, and it also seen in patients with chest wall abnormalities like flail chest, and in patients with respiratory muscle fatigue or myopathies or neural disorders like Guillain-Barré syndrome, polio, and asthma. As we have discussed earlier, mechanical ventilation is needed when there is a defect in oxygenation and ventilation, or when there is prophylactic ventilation is needed when the airway has to be protected and kept patent. So the indications of mechanical ventilation, primary indication is respiratory failure, and the prophylactic ventilation is seen in patient is expected in patients post surgeries where the patient's recovery is delayed and prolonged, and then patients where the airway needs to be protected and kept patent, as in patients with altered conscious level, and in the patients with exhaustion, where patients will be using accessory respiratory muscles and respiratory muscles excessively, that is seen in impending ventilatory failure. What are the goals of mechanical ventilation? Primary goal of mechanical ventilation is to improve oxygen and ventilation, which helps in reversing hypoxemia and respiratory acidosis. The second goal is to reduce work of breathing and relieve respiratory distress. Third is to improve pulmonary mechanics, thereby managing secretions and bronchial inflammations, and to permit lung and airway healing, thereby restoring its normal functions, and to minimize the damage to the lung and airways. And the clinical parameters, that is clinical parameters that indicates the need of mechanical ventilation is if the patient is tachypneic with a respiratory rate greater than 35, or bradypneic with a respiratory rate of less than 5 breaths per minute, if the patient is in labored breathing, or if hypoxia is seen with a saturation levels of less than 88 to 90%, or partial pressure of oxygen levels less than 55 to 60 millimeter mercury, and if the patient's ABG shows hypercapnia with a partial pressure of carbon dioxide greater than 45 to 50 millimeter mercury. And as we have discussed earlier, in indications in patients with a decreased conscious level with Glasgow Coma Scale less than 8, and in patients where the airway needs to be protected and kept patent, in example like in significant chest traumas, and patients with low tidal volume less than 5 ml per kg, and a patients with low vital capacity, that is less than 15 ml per kg. So shall I take some questions, sir?
Yes, yes, Vanitha. Dr. Subramanyam, there are a few questions in the chat
Yes,
box,
sir.
I think.
The chat box, sir. Okay.
Yes. Dr. Hari is asking
Yes, sir.
measures to avoid respiratory failure in post-operative patient.
Uh,
To avoid
Vanitha,
respiratory.
Yeah.
Vanitha, shall we go back to that respiratory failure slide there,
Yes, sir.
which you have put? Fantastic. Super. Now, if we look at respiratory failure, we
Yes,
generally describe it as two kinds of respiratory failure.
yes, sir.
The commonest, no, the two kinds are type 1 and type 2.
Yes, sir.
First, we should understand what is the difference between the type 1 and type 2 respiratory failure. The
Yes, sir.
type 1 respiratory failure, the dominant abnormality, the dominant gas exchange problem is hypoxia. Now,
Yes.
hypoxia means what is hypoxia? What level we call hypoxia? Can anybody volunteer to answer that question? Sir, shall I make it a bit more interactive?
Sure, sure, sure. Yeah, yeah.
So, when do we call it as hypoxia? Can anybody volunteer to answer this? Maybe Vanitha, you can volunteer to start
Yes,
with.
sir.
When do we call it as a hypoxia or hypoxemia?
Sir, if the partial pressure of oxygen is less than 60 millimeter mercury, sir.
Okay,
Mild,
perfect.
moderate, and severe it can be.
True, true. We call it as hypoxia when the oxygen dissolved in the blood, that is
Yes, sir.
PaO2,
Oxygen.
is less than 60 millimeters of mercury. Now, now that is the type 1 respiratory failure. Now, in the type 2 respiratory failure, the dominant gas exchange problem is increase in the carbon dioxide.
Yes, sir.
So, the normal carbon dioxide, Vanitha, can you volunteer what is the normal carbon dioxide level?
Sir, it should be less than 45, sir.
Less than 40.
Yes, sir.
We can say 35 to 40 is the normal range.
Yes, sir.
So if when do you call it as hypercapnia or type 2 respiratory failure, Vanitha?
If the partial pressure of carbon dioxide is greater than 45, sir.
You can take it as 45. You can take it as 50 also.
50,
So
yes, sir.
when it crosses above 50, then you take it as type 2 respiratory failure. Now, after a major surgery, what is the dominant abnormality we expect? Long surgery by itself is not a problem, but the surgery induces a lot of stress on the body. It could be a surgery in the abdomen, it could be a surgery in the brain, what is happening. You need to get an idea what is the problem. Usually there, type 1 is not a problem there. That means there is no abnormality in the gas exchange in the lungs.
Yes,
That means there is nothing which is preventing the oxygen from going from the lungs into the blood. As a result, most of the time, the perioperative patients, post-surgical patients, they usually don't have a dominant oxygen transfer failure. So we should look at what is happening. But most of the time, what we have is a prophylactic ventilator support. Because patient, we want them to recover from surgical insult. It could be buildup of lactic acid in blood, etc. So now I'll come to the question, measures to avoid respiratory failure in the post-operative patient. Now, when does they get respiration becomes really abnormal? When there is metabolic abnormality, patients try to compensate by increasing the breathing. They want to move out, they want to take out the carbon dioxide. The acidosis is making the breathing pattern alter. So depending on those things, you might have to titrate. Cannot have one single answer for that, but it all depends what is happening, whether it is a type 1 or the type 2 respiratory failure. In this, most of the time, it is a type 2 respiratory failure, which is a post-operative problem. Did I manage to answer, sir?
Dr.
Hello?
Dr. Hari, you're okay with the answer?
Yes, sir. Yes, sir. Thank you, sir.
You got cleared?
Yes, sir.
Okay. Anybody
Uh,
has any question?
Sir, shall I raise a few questions so that it will improve the understanding, sir?
Dr. Subramanyam,
Sir?
there are a lot of background noise coming from your side.
On my side, sir?
I don't know what is that noise.
Am I audible now, sir?
Yeah, you're audible, but some sound is coming.
Is it okay now?
Yeah,
Stopped?
I think better. Yeah.
Okay, sir. I think it might be the fan which I have. Sorry. Didn't realize. Uh, Sir, a few things which I thought we can briefly expand on. Uh, um, the first problem first thing is Vanitha went through negative pressure ventilation. Can you come to that slide, Vanitha?
Yes, sir.
Now, you can go to the next. The picture is there.
Yes, sir.
Fantastic, very good. It's a very historic picture. Most of you, if you look at this, doesn't look like a ventilator. Now, the people who developed this concept of negative pressure ventilation was basically trying to simulate the normal respiration. Now, fundamental to this understanding is what do we expect? I mean, how does a normal respiration happen? So, is it because the chest wall moves, or what is the pressure which gets the drives the gas from the atmosphere into the lungs? So here, what we have to understand the concept of negative pressure in the pleural space. So what we generally happens is when the diaphragm moves down or when the chest cage expands, the negative pressure in the pleura gets more negative. As a result, it pulls up the lungs. So they try to simulate the same thing in this negative pressure ventilator. If you see the patient's head will be outside, this will be covering mainly the thorax and abdomen. When the negative pressure is generated, it expands the chest wall. So makes the pleural pressure even more negative and drives the air automatically. That was the concept behind this. The significant shift was when we moved over to the positive pressure ventilation. Am I making it clear?
Yes, sir.
Yes, sir.
Now then the era of negative pressure is almost nearly gone. The only things which you see nowadays like this is when you have a hyper, you want to give hyperbaric oxygen therapy. There are chambers like this which can give hyperbaric oxygen therapy. So just for the sake of interest.
Yes. Shall I continue, sir?
We'll continue. Thank you.
Yes. And this slide shows the effect of positive pressure ventilation on the respiratory and cardiovascular systems. Because of positive pressure ventilation, there will be as there will be a positive pressure in the thorax, there will be a compression on pulmonary vessels, which leads to reduction in stroke volume, thereby cardiac output and pulmonary blood flow, which results in high ventilation perfusion mismatch, which again leads to hypoxemia and decrease in oxygen delivery. If we come to the effect of positive pressure ventilation on other organ systems, as we have discussed earlier, because of increased intrathoracic pressure, there will be a decrease in venous return or preload, as well as the decrease in stroke volume and cardiac output, and there will be a decrease in blood pressure. And as the cardiac output is reduced, there will be a decrease in renal blood flow and renal function as well, leading to fluid retention. And in gastrointestinal systems, as mechanical ventilation is itself a stress-related event, it might lead to stress ulcers, and ileus is expected in response to various sedative drugs used during mechanical ventilation. And as mechanical ventilation is reduced with decreased venous return from the head, it causes increased intracranial pressure. And now I will be discussing certain basic concepts and the terminologies. Compliance is nothing but the elastic properties of the lung on the chest wall. As normal compliance is calculated by a change in volume by change in pressure. Normal range is around 50 to 170 ml per centimeter of water, whereas in intubated patients, in males it is around 40 to 50 ml per centimeter of water, whereas in females it is around 35 to 45. And for easy understanding, I had put a pic here. As we can see, when a person inflates a balloon, it expands in response to the inflation. Whereas if a person inflates a football, it won't inflate. So as we can say that the balloon is has compliance, whereas the football is non-compliant. Elastance is nothing but the reverse of compliance, which is defined as a tendency of a structure to return to its original form after being stretched by an outside force. Whereas resistance is a measurement of frictional forces that must be overcome during breathing. As we can see here, in an asthmatic lung, there will be increased airway resistance because the airways will be associated with increased inflammation and swelling, and there will be increased mucus production. This concept, we can see that in a normal lung, when we plot a graph between the volume and time, when compared to a decreased compliant lung, in a decreased compliant lung, volume, the tidal volume reached will be less in a same amount of time, whereas if airway resistance is increased, the volume will be reached in increased inspiratory time. So this concept will is useful in deciding whether the patient is to be kept on a pressure controlled ventilation or a volume controlled ventilation, which I will be discussing in detail in my next class. And this shows the knobology in mechanical ventilation, that is the ventilator options that is visible on the mechanical ventilator screen. First one will be the mode, whether it is a volume controlled or pressure controlled. And that is next one is the FiO2, that is the percentage of oxygen inhaled by a person in the inspired air, and the tidal volume, respiratory rate, pressure limit, and the positive and expiratory pressure and inspiratory and expiratory ratio, which I will be discussing in my further slides. And the tidal volume is defined as the amount of gas delivered by a mechanical ventilator during a normal breathing cycle. The normal tidal volume is around 500 to 600 ml. And the FiO2 is, I have discussed, as I mentioned earlier, it is a percentage of oxygen in inspired air. In normal breathing, the FiO2 will be 21% in atmospheric air, where it can be increased up to 100% based on the need of the patient. And what is minute ventilation? Minute ventilation is the amount of the gas inhaled or exhaled in 1 minute, which is nothing but the multiplication of tidal volume into respiratory rate. And how to choose a mode of mechanical ventilation? The mode of mechanical ventilation is chosen based on the indication for mechanical ventilation, and based on whether the patient is passive or paralyzed, and whether the patient is having any comorbidities, as we know that mechanical ventilation itself is associated with various complications causing hypotension, decreased blood flow to various organs, and technical feasibility, and also on the expertise of the clinician and ICU team. Based on the modes of mechanical ventilation will be dealt in detail in my next class. And positive and expiratory pressure. As we all know that in positive pressure ventilation, we will give a gas flow to maintain the alveoli open even in the end of expiration. So this is a type of strategy to improve oxygenation. The normal PEEP value is between 5 to 10 centimeter of water. If the PEEP value is increased more than 10 centimeter of water, then it leads to increased mean airway pressure or peak inspiratory pressure. If it is greater than 35 centimeter of water, can lead to barotrauma of the lungs, and which and high PEEP values will be associated with increased hypotension, where we have to treat the patients with IV fluid loading, inotropes, and it is poorly tolerated by the patient. Sir, can I stop here, sir? Take some questions.
Sure, Vanitha. Any questions are there? Anybody has? Dr. Subramanyam, you want to explain anything?
Yes, sir. Few things which probably will add to our understanding is shall I go one by one, sir, briefly?
Yes, sir.
Now, normally, we said briefly, Vanitha discussed about shunting. Now, Vanitha, can you say how much of shunting happens in the lungs normally? Shunting of blood from.
Sir, not sure, sir, exactly.
Is that shunting? No. Normally, what happens is the blood from the left side reaches the right side, isn't it? And from the left to right, when it goes from right to left, it gets oxygenated. From left to right, it comes back to the to the right side, then goes to the lungs. Normally, about 4% of the cardiac output will not get oxygenated at all. Out of 100 mils, out 100%, nearly 5% of it doesn't go through the right side at all. So which are the things which doesn't go through the lungs before getting to the left side? They include those which supply the heart and the lungs itself. These are the two main components. And sometimes when we have patients in liver failure, where there is hepatopulmonary syndrome, it gets exaggerated. These are the common scenarios where it can happen. Other times when it can happen, shunting can happen is, let's say, for example, you have a particular lobe of a lung, which is collapsed or it is blocked. So what happens is the entire blood flowing through that doesn't get oxygenated. So the shunting will get increased. That is one concept which you have. One is the normal physiological shunting and the pathological shunting, right? Have I made it clear?
Yes, sir.
If other people, please, if you want me to expand, please let me know. I'll try to expand on a few things. Other one is dead space. We talk. What is also important for us is to have an understanding of the dead space. What is this dead space? Vanitha, can you expand a little bit on dead space?
Yes, sir. Dead space is nothing but the part of airways that is not involved in gaseous exchange, sir.
Yes, absolutely wonderful.
Yeah, so there is a
true, wonderful.
Yes, anatomical dead space and pathological dead space, sir, or physiological dead space.
Wonderful. I'll try to briefly expand so that it remains in our mind. What happens is, if we all know the air travels through the respiratory airways, different generations of respiratory airways. Now, one thing which commonly asked people is, how many times does our airway divide before we reach the alveoli? For example, if you say you have the trachea, when the trachea divides into right bronchus and left bronchus, any idea how many times it would probably divide?
16 times, I think so.
Around 22, 23 times 22. It divides. There are 23 generations of airways. Yes. And the first alveoli start appearing only after the 16th or the 17th generation. That means after the trachea divides around 17 times, just like in a complex people tree, no? So where it divides, the alveoli
terminal bronchioles.
Yes. Only it's called respiratory bronchioles, and finally terminal bronchioles will come. So it divides so many times before the alveoli start appearing. So the entire air from the nose till that area where the alveoli start appearing, it acts as a dead space, anatomical dead space. Right? That is one thing. And other thing which I want to for people to appreciate is, for example, we have alveoli. We all say alveoli has a huge surface area. One thing which helps us to understand the enormity of it is, if you lay out each alveoli side by side, for example, you take out each alveoli, put side by side, the surface area it can cover. If you put it like a tiles in your bedroom or room, no? If you put it side by side, it can occupy almost half of the football pitch or the football court. So such is the huge surface area which we have in the lungs, which takes part in the gas exchange, as well as we can sometimes use for the drug delivery also. Am I making the topic clear, sir?
Yes, sir.
Yes, sir.
Briefly, Vanitha, can you briefly go to the indications of ventilation?
Sir, shall I go to the slide or shall I?
So can you go to the slides? Can you go to the slide? It just increases the understanding of it. Okay. Now, these are you can say the general, we say as a clinical indication, but there are a few technical indications. You go to the next slide. Next slide. Here, the clinical parameters which helps us to decide whether we should put patient on ventilator or not. So can you repeat this, what you explained here, Vanitha, again, just so that we have a good understanding?
Yes, sir. If the patient seems to be having tachypnea or bradypnea, sir. with tachypnea with greater than 35 breaths per minute or bradypnea with less than 5 breaths per minute, or is the
Either the respiratory rate is too high, that is more
or
than
too low.
35, or
Yes.
too low, less than 5 breaths. Both of them are not good for us. Or the breathing looks so labored that the patient will get exhausted, which is obvious for most of us. And then there are actual indications wherein which you can see the numbers on the side. The hypoxia, that means saturation below
90, sir, 88 to 90.
So now, and we have already mentioned PaO2, we say call it as below 60 as hypoxemia. We
Yes.
probably will start to act. And hypercapnia, we already decided.
Yes.
Along with this, there are other, can you go to the next slide after this? You have put other things also. There are other also usual indications, useful indications. For example, you have a patient, you have got a surgery done, and you want to see what is happening. So you have already put a tube. You want to decide whether you want to ventilate them, whether you can extubate them. Here are a few other terminologies which are used there. In the tidal volume, which the patient is breathing, is less than 5 ml per kg. So that also is a sort of gives an indication that this patient will probably need some ventilatory support before we can decide whether we can extubate. Again, the vital capacity. It's an important concept here. Vital capacity is 15 ml per kg. If it's less than that, then any idea why vital capacity is so important? Generally, we look for, when we send for PFT also, we ask for vital capacity. Is there any indication, any reason why that is useful for?
Sir, even with labored breathing or maximum effort, patient is not getting enough air entry into the lungs, sir.
True. There are two things here. One, what is vital capacity defined as? Vital capacity is defined as
maximum amount of inhaled or exhaled air, sir, during a
you can take exhaled air. So why is it important in a perioperative patient or any other patient? The reason is the vital capacity gives us an idea how good the cough will be. It is very important that any patient who goes on ventilator support, before we take out the ventilator support, they should be able to generate a good amount of cough reflex. That means if there is any silent aspiration, secretions are stuck in the trachea or bronchi, the force which they can generate can take it out. So this gives you, if the vital capacity is less than 15 mL, you can almost say that they will not be able to generate a good effective cough, and the chances of aspiration of whatever is there in the throat is very high. And if it goes into the lungs, they will not be able to actively take it out. Is that concept clear?
Yes, sir.
Okay. And just go down the next few slides now. Now here, normally we see patients when we put a ventilator or when we decide decision is made to intubate, we will see the intensivist moving them from wherever they are to a place where they can manage the ventilation, either to the ICU or sometimes to the OT. Why is that they do? Because putting the tube is only one aspect, but putting the tube, it imposes a lot of strain on the entire body. And this slide actually highlights what are the changes happening which can affect the other part of the body. So when you paralyze, when you put a positive pressure ventilation support, these are the changes which are happening in the body. So before deciding to tube, they will get ready with all the huge armamentarium of support, so that it is oxygen, suction, the vasopressors, something to treat the heart rate if it goes slow, have a close monitoring of your heart rate, blood pressure, and all those things are monitored, because the act of paralyzing their normal breathing and putting a tube and putting on a ventilatory support puts so much stress that you have to be ready for all these consequences. That is the reason why most of the time, if the decision is made to intubate and ventilate, they will be moved to an area where we can carefully monitor these things and manage them as and when it happens.
Yes, sir.
You go to the next few slides. Fantastic. Okay, you can keep going. I think I already told. Now, the longer the patient on these organ supports, it can have effect on all the organs which you have highlighted really well. Thank you.
Yes.
Okay, we'll go to the next part, sir.
Carry on, Vanitha.
Yes, sir. So I'll be discussing about the oxygen delivery devices. As oxygen therapy is important, indications of oxygen therapy, as we have discussed earlier, where it can be hypoxia. It is hypoxia mainly, that is partial pressure of oxygen less than 55 to 60 millimeter mercury, or saturation of the blood levels is less than uh, 88 to 90 percentage. So oxygen delivery devices can be classified as variable performance or low flow devices, or high flow or fixed performance devices. The examples for variable performance or low flow devices are the nasal cannula, oxygen mask, or otherwise called as Hudson mask, and the oxygen mask with a reservoir bag. Whereas the high flow or fixed performance devices are Venturi mask, oxygen blenders with nebulizers, and high flow nasal cannula. As we can see here, nasal cannula is will be having two soft prongs attached to a tubing to attach to a source of oxygen. The FiO2 that can be delivered maximum with the nasal cannula is around 0.28 to 0.45 liters, 0.45 percentage, and the FiO2 that can be delivered to a patient is calculated with the mentioned formula here, like 20% plus 4 into the amount of oxygen we are supplementing. Uh, the disadvantage with this nasal cannula is, one thing, it is variable, it will be delivering variable FiO2, and another thing is with if we give the oxygen supplementation through nasal cannula for a prolonged period, or at high flow rate greater than maximum of 4 liter per minute, it causes dryness of nasal mucosa, and it cannot provide high flow oxygen. And the next device is simple face mask or Hudson mask, which is a transparent mask provided with side holes for the escaping of exhaled gases. Even based on the size of the face mask, the reservoir capacity will be changing from 100 to 250 ml. I mentioned earlier, this is not with the reservoir bag. This is with the mask whose reservoir capacity can, based on the mask size, the reservoir capacity can change from 100 to 250 ml. And the FiO2 is variable with flow rate. To prevent rebreathing of the exhaled gases, the minimum flow rate that should be maintained with a face mask is around 6 liter per minute. And the maximum FiO2 that can be delivered to a person through simple face mask is around 60%. And the next one is a face mask with a partial rebreathing bag. Here the reservoir bag capacity is around 1 liters. Oxygen flows directly into the reservoir bag during expiration. And there will be a capture of minimal amount of exhaled gases in the initial part of exhalation. The FiO2 that can be delivered with partial rebreathing bag is around 60 to 80% with a minimum flow rate of 8 liters per minute. And here we can see a face mask with non-rebreathing bag. So here in a non-rebreathing face mask, we can see a single wave valve between the base of the mask and the top of the bag, which closes during expiration, thereby preventing the trapping of exhaled gases into the rebreather mask. So the maximum FiO2 that can be delivered with a non-rebreather mask is around 95%, and the maximum flow rate that can be given is around 10 to 12 liter per minute. Next one is high flow or fixed performance devices, among which Venturi mask is an important one. Venturi mask works on the principle of Venturi modification of Bernoulli principle, where when oxygen passes through the narrowed Venturi valve, there will be entrainment of air from outside, and the gas and the oxygen gets mixed with the air and will be delivered to the patient. As we can see here, there will be different color coded valves with an air entrapment ports at the base of the mask. So the maximum FiO2 that can be delivered is around 24 to 60%, and the flow rate should be maintained at 4 to 12 liter per minute. And the next one is high flow nasal cannula. Here, a mixture of oxygen along with humidified compressed air will be delivered to the patient. The maximum flow rate can be maintained at 60 liters per minute, and the maximum FiO2 that can be given to a patient is around 100% with a positive end expiratory pressure of 7.4 centimeter of water. And a short notes on ventilator associated lung injury. So as we have seen that there will be
Vanitha?
Yes, sir.
Vanitha,
Yes, sir.
can we handle that oxygen therapy a little bit and then go on to the last
Okay, sir.
topic? Huh?
Yes, sir. Yes, sir.
So can we have a little bit of question translation on this, sir?
Yeah, no, there are not many questions. I think only Vanitha has understood very well. Why it's called Venturi Mosque?
Shall I wait for the our PG's to answer, sir?
Yeah, anybody can answer? Or Vanitha?
Sir, I thought it's a name of a person who invented that, sir, but I'm not sure, sir.
Right.
I mean, other question commonly asked is this Venturi principle or this Bernoulli's principle. Where else is it used? Is it used in the medical applications or common applications? Anywhere is it used?
Yes, sir. To determine the flow of fluids, sir, one thing in physics we have come across. Sir.
I'll briefly. I'm not sure, very sure that have you people seen a foot suction, where in which if you press the in a pedal, the suction works. Any of you have tried it?
Sir.
For example, let's
No,
say
sir.
you have a critical ill patient who you want to transfer from one ward to another ward. So you want to have a suction mechanism if the patient vomits or anything. So these foot suctions are still available in a lot of hospitals. It's like almost like a foot pedal. If you press it, the negative suction comes. It can suck it out. So the commonest place where you have your the commonly used deodorant, all those things. When you press the lever, by negative pressure it suctions out. So shall I briefly expand on the few things which is run through? Now, this
Yes,
Venturi mask, you can see the first thing slide which Vanitha put was on fixed performance and variable performance. Any idea what it means, Vanitha? What is fixed performance? What is variable performance?
sir, based on the FiO2 delivered to the patient, sir, amount of oxygen, percentage of oxygen delivery to the patient.
I will give a context to this to help us understand. For example, you have a patient who is breathing at a rate of 5 per minute. It's a 10 per minute. So the patient is breathing at a rate of 10 per minute. That means every 6 seconds he is taking a breath. Right? If he's taking at that rate, the amount of oxygen delivered from this variable performance will be very different if the patient is breathing at a 30 per minute. So because the time for inspiration is very less there and the flow rate is very low, so that the amount of SiO2 which the patient gets is very low in a variable performance. Whereas in a fixed performance device, irrespective of the respiratory rate, the FiO2 delivered will be constant. That means if you thought that, let's say I want to give an FiO2 of 0.4 for this patient. So the devices which you have to choose is among those on the right side. Those on the left side, the FiO2 delivered will be variable according to the respiratory effort and the respiratory rate. That is the big difference between these two. Now, what also is obvious in this cannula is she started from nasal cannula at the start, which said as variable performance, and again she has finished with the nasal cannula. Any difference between these two cannulas, Vanitha?
Positive
No,
and
not.
tertiary.
Yes,
Now,
sir.
It gives it the positive pressure, no, sir.
True. What I mean, the big difference was initially when we started using nasal cannulas, we all thought that yes, because it's a dry oxygen coming through it, it will irritate the nose. The patient will not tolerate it, and it will make the secretions dry. That was how we had thought it, and
Yes.
we were using only the nerves as the reservoir while providing this. But this high flow nasal cannulas, they come with a humidification device, and you see the
Yes.
humidification device attached to it,
Yes.
and it can give a flow rate which can actually give the entire requirements what patient requires. So the entrainment from the room air will be very limited, and it is humidified, and because it is giving at a flow rate in excess of 45 25 liters per minute, it almost acts as a CPAP device or a PEEP device. So that means the positive pressure is there all the time. So one of the important concepts which we generally look at is, when our vocal cords are active, so it creates a positive pressure automatically when we breathe out. But when you intubate a patient, that vocal cords acting as a positive pressure is gone. So a lot of times that moment that positive pressure peak is gone, the lungs can go into collapse or atelectasis. So this one, what happens is, in this is a new device which has been popular over the last 4 or 5 years. It has made entry not only in the intensive care, not only the neonatal care, in the perioperative patient. Let's say, for example, you have a lot of patients who require rapid sequence, your anesthesia rapid sequence induction. This device, you don't need to ventilate like other patients we do. So you just keep it on, it automatically maintains oxygenation. The reason is it increases the mass flow. We call it as passive movement of the air from the nose to the lungs. So this has been a fairly popular device which is being used effectively for rapid sequence induction, post extubation, especially nowadays, after almost every major surgery, when you're ventilating for more than 24 hours, instead of going on to normal oxygen, so we're trying to put them on these high flow devices and take out the tube as early as possible. And this can almost deliver the 100% oxygen if you want to, but usually you can't, very difficult to deliver more than 90%, but it's almost say as high as possible.
Yes, sir. Shall I continue, sir?
Shall I go on to the last part?
Yes, sir.
Sir, one question, sir. Sir, for this, what are the mask we have discussed now, sir? The amount of oxygen required, like 4 liter, 6 liter face mask and all. Is it all applies the same for COVID patients, or like we should not avoid some mask or oxygen device for COVID patients?
Now, initially, when we started, people started to look after these COVID patients. There was a lot of fear about aerosol generation. When they cough, when they come out, there's a lot of aerosols will come out. If you put them on these devices, they are actively, generating aerosols. That was the main concern. And people thought it was much easier. You put the tube on, you put them on a closed circuit, and then it will not contaminate the room air. That was the popular belief. So because more for the fear of other people. But gradually they realized that if you ventilate, the mortality is very high. And patients, most of them may not need ventilator support at all. So the environment is a bit contaminated, yes, because of aerosol, patient coughing out, sometimes secretions here and there. But for the patient, if you put them on ventilator, nearly 8 out of 10 died initially. And they said, you put them on ventilator, don't try to extubate them for nearly 10 days, keep ventilating them, then decide, do take oxygen and wake up. So then after that, we decided that no, most of them, even though they may require oxygen, that is because the lungs has developed an intrinsic where gas exchange is not happening. We can just manage with oxygen therapy. So it is not a type 2 respiratory failure. It is CO2 is fairly well maintained because patient is maintaining respiratory effort. It is because of the edema in the lungs which is happening there. So they decided that yes, we can continue with oxygen. Now, avoiding intubation has become a priority now rather than necessity now. So we try to keep them on the spontaneous ventilation, spontaneous breathing, and just keep supplementing with oxygen, initially with lower FiO2s with nasal catheter. If it goes higher, then put on face mask. If it still needs higher, face mask with a reservoir bag. If it still they don't match, you can go on to high flow nasal cannula. Still required non-invasive ventilation. Still required, go on ventilator. That is how it has been there. Okay. Stepwise progress rather than directly going from room air, just oxygen directly to ventilator.
Yes, sir.
Okay.
Shall I continue, sir?
Yes, ma'am.
Yes, sir. So as we have discussed earlier, during mechanical ventilation, we will be giving a volume of gas to the patients, which can induce a trauma to the alveoli, as well as the pressure that is pressure of the gas that is given to the patient can cause barotrauma, and the sensitive, because of the sensitive stimulation on the alveoli, because of changes in repeated pressure, changes in pressures or volume, can lead to biotrauma. And the one of the most important complication with ventilator is the oxygen toxicity. And because of the continuous expansion and and the collapse of the alveoli can lead to recruitment de-recruitment injury because of inflammation and edema of the alveoli. And because of the change in the alveoli shapes due to supplemented volume or pressure can lead to shearing injury. And what is the difference between ventilator associated lung injury and ventilator induced lung injury is we do give mechanical ventilation to two types of patients. Patients with acute respiratory failure with normal lung before, or with a patient with chronic respiratory failure has come up with acute failure. So ventilator induced lung injury is seen in a the patients ventilated after patients with a normal lungs after ventilation. So to manage the ventilator associated lung injury, ARDS research network study has come up with a concept of lung protective ventilation, where we do set the ventilator settings initially with a minimizing FiO2 and with reduced plateau pressure of less than or equal to 30 centimeters of water and a minimal tidal volume of around 66 to 8 ml per kg. And the PEEP is set according to the patient's need, starting from minimal to limit atelectasis and shunting. And as we have discussed before, these are the initial ventilator settings that will be seen during lung protective ventilation with an FiO2 of 1 initially, but then reduce, aiming for saturation of around 93 to 98%, and the minimal PEEP starting from 5 centimeter of water, and the tidal volume around maintaining around 6 to 8 ml per kg, and with the inspiratory pressure of around 20 centimeter of water, and the respiratory rate at 10 to 15 breaths per minute, and the inspiratory expiratory ratio is around 1:2 with a flow trigger of 2 liters per minute and the pressure trigger of -1 to -3 centimeter of water. So how a mechanical ventilator improves the patient's oxygenation? By changing the settings like FiO2 or PEEP, altering inspiratory expiratory ratios, and lung recruitment strategies. In lung recruitment strategies, we do give a positive high pressure to the where the lung is exposed to the high pressures for a short time period. For example, giving CPAP at 40 centimeter of water for 40 seconds. And prone position is one of the strategies to optimize oxygenation by recruiting the collapsed alveoli as well as by increasing the perfusion. And what is permissive hypercapnia? In patients with obstructive lung diseases where the patient cannot ventilate properly and cannot take a breath, where the patient will be having a prolonged inspiration. So there we do allow some carbon dioxide to built in the alveoli, so that patient can ventilate properly. So this slide shows the management strategies during mechanical ventilation and permissive hypercapnia. There will be decreased, we will be reducing the peak inspiratory pressure, plateau pressures in order to reduce the likelihood of lung injury. And we do allow to build up a minimal carbon dioxide inside the lungs, which is termed as permissive hypercapnia, until the patient doesn't land up in danger levels of acidosis. And there will be decreased pH acidosis, which can be treated by tromethamine, which is a buffer, non-bicarbonate buffer. And atelectasis can be managed by adding PEEP, and hypoxia can be managed by increasing FiO2 or adding PEEP. And the application of permissive hypercapnia can be seen in sepsis and ARDS. And this slide shows the indications for weaning. When do we wean a patient? When the underlying illness is treated or improving, or when the respiratory functions of a patient is restoring to the normal levels with a respiratory rate of less than 35 breaths per minute, and the FiO2 is less than, patient is requiring an FiO2 of less than 0.5 and maintaining a saturation levels of 90%, and when he is requiring a PEEP of less than 10 centimeter of water, and if that he is able to maintain the tidal volume of greater than 5 ml per kg, vital capacity greater than 10 ml per kg, and when his minute volume is less than 10 liter per minute, and when the patient is not having any infection or fever, he is stable in terms of his cardiovascular status, and he is maintaining optimal fluid balance and electrolyte balances. How can we determine the failure of weaning? When the after weaning the patient, if we see a respiratory distress in the patient, or patient is having tachypnea, tachycardia, or hypertension, and when his tidal volume is reduced, we can say that the patient is not ready to wean. And it is sensible to wean at early in the morning so that we can monitor the patient a whole day, whether he is tolerating or not. In prolonged weaning, it is advisable to supplement overnight ventilatory support to give rest to the patient. That's it, sir. Thank you, sir. Sir?
Thank you, Vanitha. I think Dr. Subramanyam.
Sir, am I audible now?
Yeah, you are audible. You can.
So one of the attempts which Vanitha has made here is she has tried to cover all the aspects of respiratory support. Mechanical ventilation is one part of the respiratory support. The other part, now, if we go through the respiratory support, so step by step, the first part of the respiratory support will be to supplement the oxygenation of the lungs. So initially, if you look at the first slide, what she said was ventilation involves giving oxygen, helping the oxygen transfer into the blood from the lungs, and taking out the carbon dioxide from the lungs so that whatever carbon dioxide buildup in the blood is taken out. So initially, now she has covered most of the non-invasive way of supporting the respiration. That is giving oxygen when it is needed, how to give oxygen, what are the different ways of giving oxygen, and which gives higher SiO2. And depending on your ABG measurements, you can see whether you need to go up by one level, that is going up from minimal support to advanced support, what we have seen. Now, when we put patients on ventilator, it can easily not only, it's being a mechanical and invasive support, it can have a lot of effects on the different parts of the body. So initially she mentioned the effects which can have on the other part of the body, including the stomach, including the kidney, the perfusion, cardiac, etc. That was one part where in which the effect of mechanical ventilation is on the different part of the body. Then she came back to handle what happens in the lung if you're not watching out. So you want to give oxygen, you want to give carbon dioxide, but because it is not a normal physiological mechanism, that itself causes an injury into the lungs, which is in the form of biotrauma, barotrauma, volutrauma, and all other aspects. So oxygen toxicity. Now, normally about oxygen toxicity, I want to give one natural or a common thumb rule. So our concentration focuses usually on improving the oxygenation, getting the PaO2 to as high as possible. But what happens is if you are giving oxygen more than 60%, for more than 60 minutes, you are likely to start seeing some kind of oxygen toxicity. I'll repeat it again. If you are giving oxygen more than 60% for 60 minutes, some kind of oxygen related free radical injury will start developing in the lungs. So if you're giving more than that, we always try to come down to 60 because that is usually seen as a threshold beyond which oxygen free radical injury starts happening. The other thing when we start about ventilating is using the recruitment maneuvers quite well. You probably would have seen normally also, even when I'm talking now, I'm taking normal breaths. Suddenly, intermittently, I will take a deep breath. That means it will expand every part of the lungs. The same thing holds good when we put on patients on ventilator. I mean, next slide, Vanitha.
Yes, sir.
Go to next. So we will come to this aspect of the graphs next class probably as quickly as possible. Now this ARDSNet study is a very landmark study, a big landmark study, which was probably came out in 99 or 2000, which changed the way we looked at ventilation. And one is in the in the enthusiasm to give them oxygen, a lot of damage used to happen to lungs. These key findings, what are the settings there? We'll come back to that, revisit at the end of the next class. So you have to see that how we have adopted almost all the findings of this in the practical everyday ventilation, not only in the ICU, but also in the long cases in the OT, when we have the current anesthesia machines which can cater to different needs. Now, next aspect, we can go. Now, there are a few aspects which helps optimizing the oxygenation. So, I'm pretty sure that most of the people have heard about prone positioning now, because the prone positioning is being adopted in COVID disease. Even more so, they are helping say we can do awake prone positioning. One of the important concepts which you have to remember is different parts of the lungs. Even normally also, the perfusion is very different. If you can divide it upper, mid, and lower zones, the perfusion and the ventilation is not the same in all aspects. So when we turn them prone, it improves the oxygenated areas, and where the perfusion is happening, the oxygen goes to those parts. So the prone positioning is something. And then she dealt about weaning. Now, can anybody explain what does weaning means? When does it apply? For example, we have had a big case. Let's say we have had a Whipple surgery, and tomorrow morning we'll plan to extubate. Does the weaning concept apply, Vanitha?
Sir, not sure, sir.
Normally, we use the term weaning when we have ventilated a patient for more than 48 hours. That means you can't take out the ventilator just like that. You can extubate just like post-operative. You can't do that because their body has got used to the ventilator support. That means not only the physical act of generating the negative pressure and all those things, also other aspects like oxygen transfer within the lungs, all those are still getting adjusted. So you can't take out like a post-operative patient. You need a plan to slowly reduce the support, increase the work of breathing of the patient, and take it out. This usually we take it at 48 hours as the duration, where in which if the patient is ventilated beyond 48 hours, you need to make a plan how you will take out the ventilator support, how you will reduce it, and finally take out. That is the plan for weaning. Now, when you start weaning, you have laid out the criteria. Commonly, majority of times people ask, what is your criteria for weaning? What is your plan, how you wean the patient? So we will see tomorrow, before we finish the class, what are the different ways we can take the patient out of the ventilator support and help them slowly gain their normal physiological respiration. Can you go to the next slide if there's anything else? Okay. We'll come back to that again. Probably this should have been dealt at the end, but Vanitha has found, because she wanted to squeeze this time, whatever we have today, and we will briefly deal with it again tomorrow. Thank you, sir. That's it for us from my side, sir.
Thank you, Dr. Subramanyam. I think there's a lot to learn, lot of learning. I think once there was a important main question for DNB on mechanical ventilation. I think that's why Dr. Vanitha wanted to do this topic. Tough topic, but there is a lot of learning. I think by presenting, Vanitha has understood much better than all other students. Better to go through this again and again and understand better. And Dr. Subramanyam has explained very well in simple terms. One thing, Dr. Subramanyam, what is VAP you want to cover in this, ventilator associated pneumonia?
We will cover it, sir. Next time we can cover it, sir. We can cover it. One of the concepts which has slowly developed is biotrauma. What is happening to the at the bronchial and the microvascular level, which makes the patient prone for ventilator-associated pneumonia. I'll briefly tell gross view what is happening. Normally, we have the villi which are lining the respiratory tract, which are easily able to take out whatever secretions, whatever mucus is there, can easily come out. The moment you put them on, paralyze them or put a endotracheal tube, that mechanism is lost. On top of it, we are connecting to a mechanical ventilator where the airflow pattern is different. So I'll briefly deal with ventilator associated injury next time, sir.
Right, right. So thank you very much. I think we'll close it today. Dr. Vanitha,
Yes,
you have
sir.
done a very good job.
Thank you, sir.
When is the next class you're planning?
Sir, it is about 25th, sir. We are around 26th, like that, sir.
Right, right, right. Dr. Subramanyam, thank you very much. You have made it very nice and made everybody to understand the difficult topic. Thank you very much.
Thank you, sir. Thank you, sir. Thank you very much. Thank you, all of you.
Thank you, sir.
Thank you, sir.